So today's topic is the autonomic nervous system. And the autonomic nervous system is a system which used to be called vegetative before, but now we do not prefer this term, as vegetative state means a state of the patient who is lying without any communication with the outside world. That's why we prefer to call it autonomic, which tell us that it can work without our will. So it's an involuntary system and we are not obliged to care about that. The autonomic system is visceromotor system. That means efferent coming from central nervous system into the peripheral one. And it consists of three main parts: sympathetic, parasympathetic, and then enteric system. We will talk about the enteric system a bit at the end. But now about the sympathetic and parasympathetic. As you can see from the figure, sympathetic means you would like to fight or flight, or you are a bit fried, so you have to be activated. And for activation, what you need is to prepare your heart, so the heart will beat more, the bronchi will be dilated, the sphincters will be closed, the eyes are dilated and opened, so you are ready for action. On the contrary, parasympathetic means rest or digest. So you can imagine a newborn after feeding from the breast, that your newborn is lying, easily digesting, so the sphincters can be relaxed, the eye can be closed and the pupil is smaller, the heart beats slowly, and the bronchi can be a bit constricted. Yeah, so if you imagine this, you will understand nearly all the functions of the sympathetic and parasympathetic trunk and how and how the organs behave during activation of one of these. So to make a general statement, what are the main functions? The main functions concern smooth muscles and glands and heart mainly. So not a striated muscle, but non-striated muscle. So it's contraction and relaxation of smooth muscles, either in vessels or in all other organs, contraction and relaxation of the heart muscle, and then function of all glands, all endocrine and the majority of the exocrine glands. And it can even affect some metabolic processes like lipolysis, that means degradation of the adipose tissue, or glycogenolysis in liver and so on. So these are the main functions. And as I said, we can divide it into sympathetic, parasympathetic, and enteric system. All the autonomic system are only visceromotor fibers. So we talk about the nuclei in spinal cord or brain stem, and they leave the spinal cord or brain stem via the nerves. They enter the autonomic ganglia, and in autonomic ganglia, they are synapsed. The preganglionic fibers are all the time myelinated, so that means they are wide, they are quite quick. But the ganglia, they reduce the speed, and then from the ganglia, after the synapsing, then the postganglionic fibers are unmyelinated, so they are gray, and the transmission is slower. So the autonomic nervous system, in comparison to the somatomotor fibers, it's slower and it's more diffuse. Yeah. So we talk just about these visceromotor fibers, parasympathetic and sympathetic. But inside these fibers, there are opposite fibers coming from free nerve endings from organs. They are called viscerosensory fibers. Yeah. Of course, they are not sympathetic and parasympathetic, but they travel in the same nerves, and they are connected to the local reflexes of the sympathetic and parasympathetic system. Right? So these viscerosensory fibers come from all the organs, gastrointestinal, respiratory, urogenital, but also from vessels. Yeah, and they inform you about extension and relaxation of these organs. If there is a pain in the organ, for example, a colic, which we can have in the excretory urinal system, yeah, in renal pelvis, in ureter, or in biliary tree, for example, or if there's any ischemic pain in coronary arteries and heart, for example. So all this information is transmitted via the viscerosensory fibers, which travel together with the sympathetic and parasympathetic in the opposite direction. Yes? So this figure shows you the main difference between parasympathetic and sympathetic system. Yeah. So now we will talk about these main information. So first, sympathetic. You can see that the sympathetic leaves the spinal cord only in these segments. Which are these segments? They are usually C8 to L3, but they can be T1 to L2. Yeah, so it can be variable, but mainly or usually it's C8 to L3. It means that the fibers go from centers which are in the brain, and they go down here, and here they can leave the spinal cord via the spinal nerve into the trunk. This is called sympathetic trunk. I think you know all the sympathetic trunk, which is running along the spinal cord. And for example, for the eye, they travel this way up. They are synapsed. For the eye, they are synapsed here. And then the postganglionic fiber continues into the eye. Yeah. Why it's not going directly here, we don't know. It's a developmental consequence. So all the fibers which go to the head, they have to go down to the level of C8 and leave here the spinal cord and go back via this trunk. Yeah. Similar situation is down for the pelvis. They have to go down here, leave in the last one, L3 usually. Then they are synapsed, and then they go into pelvis, for example, to uterus and vagina. Yeah. So that's why we call this system also thoracolumbar, as the sympathetic system leaves the spinal cord only within the thoracic and some lumbar spinal nerves. So that's first information. The second information, that they can be synapsed either here in these ganglia, or they can pass and they can be synapsed here. So there are two kinds of ganglia. Yeah, these ones are called paravertebral, as we find them next to the vertebral column. Yeah, so the paravertebral ones, they are the same as sympathetic trunk. Yeah, so sympathetic trunk is the same as paravertebral ganglia. The other ganglia, which I can circle here, these ganglia, we call prevertebral. Yeah? Prevertebral. They are located more ventrally. They form something which is called abdominal aortic plexus. Why it's like there? Why it's like that? Some of the some of the populations of the neural crest cells, which are the developmental base for these ganglia. Some stopped here, some traveled a bit farther and stopped here. Yeah, so they are originally the same group of neurons with similar function, but some of them stayed next to the vertebral column, some moved in front of aorta. Yeah, so you have to distinguish the prevertebral and paravertebral. But every fiber which goes is interpolated or synapsed only once, either in paravertebral or in prevertebral. Yes, only once. Another important information is that the ganglia are very close to the spinal cord. Yes, so they are located centrally. If you look at the parasympathetic system, they are located much more in periphery. So these are the most important morphological information about sympathetic system. Yeah, leaf spinal cord at level of C8 to L3 is synapsed either in paravertebral ganglia of the sympathetic trunk or in prevertebral ganglia of abdominal aortic plexus, which is located more centrally. And then the postganglionic fibers goes to the organs. For the head, it has to go down to level C8 and then up again. As for parasympathetic, if you look to the parasympathetic, some information are similar. Yeah, the information starts somewhere in the brain centers and then go either via cranial nerves to a ganglion, it's synapsed, and then to the organ, yeah, like to the eye. So you can see the difference between parasympathetic information for the eye and sympathetic information for the eye, that it travels in a different way. It leaves the brain in 4 cranial nerves. In which cranial nerves? It's oculomotor, facial, glossopharyngeal, and vagus. Yeah? The first 3 ones are destined for nuclei which are in the skull. Ciliary, pterygopalatine, submandibular, aortic. You all know where they are located. We will talk about them in detail later. And the 4th one, the vagus, descends down and supplies everything which we find in thoracic cavity. So these 2 organs plus thymus as well. And then in abdominal cavity, which is GIT, and it's foregut and midgut. Yeah, derivates foregut plus midgut. Yeah, and of course kidneys, spleen, and testis, ovary. So this is just the main overview. Kidney, spleen, testis, and ovary, they are located in approximately the same level during the development, so that's why. And it terminates at so-called point of Canon Böhme. You may remember that it's a Canon Böhme. And this point is a border between midgut and hindgut. Yeah, that means that this part innervates hindgut plus a lesser pelvis organ. Yeah, how we call this part? As you can see, it leaves S2, S3, S4. Yeah, and it forms one common plexus here. We will talk about this. So you can see that parasympathetic system is system of the head and sacral area. So we call it craniosacral system. Yeah. So these are 2 major differences between sympathetic and parasympathetic. where it leaves the spinal cord, and where are located the ganglia. The ganglia for the other organs here, you can see they are located in the wall of the organ. Yeah, in the wall of the organ. So we call them intramural. Yeah, we call them intramural, inside the wall. That means the parasympathetic ganglia are located in periphery, very close to the organ, unlike the sympathetic one, which are located centrally. That means close to the spinal cord. Yes. So, any question to this general information? If there is no question, I can continue. And in the presentation, you have more slides showing the same. Here you have switch sides, sympathetic and parasympathetic, and you can see which organs are innervated by which nerves and from which segments of the spinal cord and brainstem. Yeah. So another important information is that sympathetic and parasympathetic system use different neurotransmitters at preganglionic and postganglionic fibers, and it is important for pharmacotherapy and physiology. Yeah, when we will talk about, or you will learn physiology and then pharmacology, you will come to many remedies, medicaments which block these receptors or which activate them. So you should understand where the receptors are. So we have a receptor, which has been found that it's that nicotine, which is one substance in cigarettes, in tobacco, that this receptor and the nicotine is the most suitable ligand for this receptor, yeah, ligand. That's why we call it a nicotine receptor. And we can find this nicotine receptor, as you can see, in skeletal system. So this is somatomotor fiber, yeah, and it's a neuromuscular plate. So this has nothing common with autonomic system, but acetylcholine as a neurotransmitter uses this nicotine receptor in neuromuscular plate. Yeah, so that's for skeletal. Now we come to autonomic system. If we see the autonomic system, where are the nicotine receptors for acetylcholine? You can see them here. These are preganglionic fibers. Yeah, this is CNS, and this is ganglion. So you can see that they are used by the axons of the CNS neurons. Yeah, so they are preganglionic, and they are preganglionic both for sympathetic and parasympathetic. Yeah, so that's very important that acetylcholine is used for all preganglionic, autonomic, and for somatomotor neuromuscular plate. For postganglionic fibers, we have another receptor. We have noradrenergic receptor for noradrenaline or norepinephrine. Yeah, it is also suitable for adrenaline or epinephrine, dopamine, and so on. And we can see that we find them at the postganglionic fibers of the sympathetic system. Yeah, here you can see the blood vessels, but the same is for the heart, the same is for the GIT, yeah, for all the sympathetic ones. Of course, there's an exception. And the exception, and we don't know why the exception is in sweat glands, where the receptor is not for adrenaline, but it's for acetylcholine. But the receptor is different. It is not a nicotine, it is a muscarine receptor. And muscarine is one of the poisons which you can find in this mushroom. And I don't know the proper English name for this mushroom. It's some amanita in Latin, yeah, but this mushroom was used by witches to make teas and to make tinctures and to drink it, and then they have some psychedelic effects, yeah. But I think you all know this from our forests. If you go outside, you can see them. So acetylcholine using muscarine receptors. Yeah, so that's an exception. And another exception is here, as adrenal medulla. Yeah, adrenal medulla is a ganglion. It's in a suprarenal gland, and the main production of adrenal medulla or suprarenal gland medulla is adrenaline and noradrenaline, yeah, epinephrine or epinephrine. So it's a ganglion which has changed into an endocrine gland. That's why we have here also the same as here, yeah. That means acetylcholine using a nicotine receptor. And to conclude, for parasympathetic system, yeah, the postganglionic fibers which are used are these. That means the same as here. The acetylcholine uses muscarine receptors. So to conclude, we have three kinds of receptors: nicotine and muscarine receptors for acetylcholine. Yeah, and you can see the difference that the nicotine are in the ganglia, so on the preganglionic fibers, and in neuromuscular plate, which is here in somatomotor, and muscarine receptors are in target tissue of the parasympathetic, yeah, which is here, and one exception, sweat glands for sympathetic. And then we have noradrenergic receptors, and as you can see, we have four kinds of them, yeah, alpha 1, alpha 2, beta 1, beta 2, yeah, and they are target tissues of sympathetic. And this, if you learn it, you will use it in physiology, pathophysiology, pharmacology. You will use this in your life as well. Questions? If there are no questions, let's go on. How it's used in clinics. In clinics, it's used in the way that we have some medicaments, and these medicaments can stimulate or inhibit the receptors. So for example, for sympathetic system, the mimetics, which means they are plus, they are stimulating sympathetic system. We can have some natural, like adrenaline, noradrenaline, dopamine, yeah, which you already know, and then some clinical ones, which is not necessary for you to know, yeah. So we can use this. When you use sympathomimetics, you have a patient with a heart failure, the heart stopped, then you are not able to start to stop it with the massage or so. You can use the adrenaline to put it into the circulation system, and the adrenaline can start the heart, yeah, as it stimulates the sympathetic system, and sympathetic system stimulates all the functions of the heart. Very easy. Similar for parasympathetic system, yeah, acetylcholine, that's the natural ligand of this. And we have some other ones which are clinical. Organophosphates are fertilizers, which have been used in many countries in previous years to fertilize the fields, but they are quite effective poisons. Yeah, so they can cause activation of parasympathetic, and if to activate parasympathetic too much, you can stop the heart. Yeah, as parasympathetic system lowers the heart function. And then we have the inhibiting one. Yeah, so the inhibiting one has got similar function. So sympathetic system can be blocked, or parasympathetic system can be activated, and their effects are not identical, but they are similar. Yeah, and of course it depends on the medicament, where and how it works, but generally they are quite similar. So the sympatholytics, that means they block the function, we can distinguish as for the alpha 1, alpha 2 receptors, beta 1 and beta 2 receptors. Yeah? Why it's so important? As for example, beta 1 are in heart, 2 in bronchi. So imagine you have a patient with hypertension and the heart runs too quick. So what do? You can, for example, block the sympathetic system to reduce the heart rate. Yeah, so you use a beta blocker, but you need a beta 1 blocker. Yeah, in case you have a patient who's got problems with bronchi like asthma and the bronchi are too narrowed and they are in a spasm. So if you give just an non-selective beta blocker, you can reduce the heart and help, but you can close the bronchi, yeah, as the sympathetic system widens the bronchi. If you use the beta blocker, it, on the contrary, constricts the bronchi. And what happens to the patient? He suffocates and can die. So you have to think then in future which medicaments you use, and now you should know approximately in which organs are which of these receptors. Yeah, all the receptors you will learn in physiology, pathophysiology, but as for now, you should know some basic information I will show you in next slides. So you can see different medicaments here, yeah, which are used in clinics. Of course, not necessary to know these names, but you can see that some of them are alpha, some of them are beta selective, yeah, and some of them can be, of course, beta 1, beta 2. And for parasympathetics, yeah, that means which blocks parasympathetic system. There is no natural one in the body, but there are some natural in plants, for example, as you can see here, the Atropa belladonna, which is one of the most poisoning plants in our country. Yeah, it looks like a nice blueberry, but if you eat it, two of these can kill a kid and 10 of these can kill you. Yeah, and inside is atropine. Scopolamine is, for example, in the red amanita, which I showed you before. Yeah, ipratropium is then used as a medicament. So for these, you can remember these name of these substances which are highlighted. And I think for your life of a physician, you should even now remember the 3 contraindications when you cannot use the parasympathetics. That means the blockers of the parasympathetic system. Well, what is paralytic ileus? Ileus means that in your GIT, in ileum, but in all GIT, there's a paralysis of the movements. That means paralysis of peristaltics, no peristaltics. Yeah, and parasympathetic system is responsible for digestion. That means for peristaltics. So if you use the parasympathetics, that means you stop parasympathetic. In case it's already stopped, then there is no movement in GIT, yeah, and a rupture of intestine can occur. So paralytic ileus is 1. Hyperplasia of prostate. Why hyperplasia of prostate? Parasympathetic system opens the sphincters. In case you block it, it does not open the sphincters. And if you have hyperplasia of prostate, it means you have problem with urination. Yeah, and if you block opening of the sphincter, you have retention of urine, and the danger of hydronephrosis. And third one is glaucoma, which is a problem with the eye, and we will talk about this in eye. Yeah, just now you can remember that. So there are 2 questions. Does adrenaline have the same effects as adrenaline? Yes, but it depends on the precise kind of the receptor and organ. So some of them can be more active, yeah, stronger or weaker. Can I also reduce heart rate by parasympathomimetics? Of course, yes, you can. Yeah, the parasympathomimetics and sympathetics has got the same function, but they use different systems, and it depends if you administer this drug to a patient, then it, of course, you administer it into the circulation system, and it can take it not only to the heart but also to the other organs. So then it's a problem of the pharmacology. Yeah, and we will talk about this later in the 4th year. So questions to this. This is to understand why you should know the receptors and the main substances which bind to these receptors. Yeah. Okay. So, and then to know in which organs is which receptors, you have here a table. I would stress here, just due to lack of time, that B1 is in heart and B2 is in, for example, bronchi. Yeah. B3 is only in adipose tissue. So this is what we have talked about, B1, B2. If you look at A1, A1 is in vessels. And in eye, dilator of pupil, we will talk about this. Yeah? And alpha 2 is presynaptic in synapses. Yeah? So it inhibits a mediator releasing, so it's a neuromodulator. So these are the main ones, but you should go through all of these to then, you will use this definitely in clinical medicine. Yeah? So this is your homework. And then to help you more to understand it during your studying at home, for every receptor you have here the main functions, yeah, which are written here. So you can go through it. For example, for the B1, we have here all this information for the heart. You can see that everything goes up. And you have to learn also the names which are used for these functions. You will use this definitely again in physiology, pathophysiology. Yeah. So, as I said, the receptors and their functions is your homework. Yeah. We have talked about here B2 receptor, bronchodilation, but it's not only bronchodilation. Yeah. But it's, for example, vasodilation in skeletal muscles. Yeah. Relaxation of the intestinal wall, and as I said, there are some metabolic ones, glycogenolysis. So you elevate glycemia by glycogenolysis. So the glycogen from liver, which serves as a storage for glucose in a form of glycogen. Then it's started. Yeah. So, as I said, this is an homework because it's not a problem, everything is written here. For parasympathetic part, it's easier as we have the nicotine receptor, yeah, and we set neuromuscular plate in somatomotor ones and ganglia, that means preganglionic, yeah, preganglionic visceromotor. So this is nicotine receptor, and then the muscarine receptor. There are more of them, but it is not necessary to know these numbers in detail. You just should know that it's in nerves, heart, smooth muscles, and glands. Yeah. And again, the parasympathetic system. What is the function of the parasympathetic system? In the body, in the heart, everything goes down. Yeah, everything is negative. For the eye, it's sphincter, and we already know this as it's supplied by oculomotor nerve. The same ciliar, which is for accommodation. So if you would like to look at near objects, yeah. And then of course for all other ones. Yeah, we have talked about the urinary bladder, that parasympathetic lytics cannot be administered in hyperplasia of prostate glands, yeah, because in urinary bladder we have a relaxation of sphincter and a contraction of the detrusor, which empties the urinary bladder. If you block the parasympathetic system here, this does not work and you have a retention of urine. Yeah. All this makes nicely sense, yeah, because physiology makes sense all the time. So this is quite easy then to learn it, but we have to go back to anatomy to understand the pathways, which are not so easy. Yeah. So what we need, if you have any question to this, which is not much anatomy, but the receptors are very important, especially for the functioning of the system. And you know, in anatomy we learn not only the morphology but also the function. So how now we get the autonomic information from spinal cord towards the organs? Yeah. Luckily we know this. We start here. Where is the nucleus for autonomic system? Yeah, the nucleus is called intermedio lateral nucleus, yeah, and it's in the lateral horn, of course. So we can go from the lateral horn and we go through anterior root to the spinal nerve itself, yeah, and from the spinal nerve, as the fiber is myelinated, so it's white, you go through white communicating branch, ramus communicans albus. Sorry, I drew a bad one. I have to circle, of course, this one, yeah. White communicating branch, yeah, myelinated fiber, and it comes to the sympathetic trunk. Yeah, this is sympathetic trunk, and it's the same as we said. It's also paravertebral ganglia, which are forming the trunk. Yeah, so paravertebral ganglia, and the fiber can either synapse or it can go to synapse in another ganglia, which are located in front of aorta. So we call them prevertebral ganglia, yeah. Or it can go down and synapse, yeah. Or it can go down and synapse in paravertebral ganglia. Or it can go up. For example, if you come back to the head and synapse, yeah, and then it can go to the organ. And to the organ, as you can see, it's this interrupted line because it's already unmyelinated gray, yeah, so it can leave either via these fibers or via the gray communicating branch, ramus communicans griseus, and it can join the different branches of the spinal nerve, yeah, for the skin glands, for the vessels here, for the vessels of meninges. So this is what you already know, just to be sure that you are oriented, and we can continue into the sympathetic system, which we call thoracolumbar, as it leaves from the level of C8 to level of L3, yeah. So you can see this here, C8 to L3, and then it supplies different organs, yeah. Nicely, we can see here the prevertebral ganglia and the paravertebral ganglia, which are part of the sympathetic trunk. So, what is sympathetic trunk? It's a chain of ganglia, which are called paravertebral. The number of the ganglia is a bit lower than the number of vertebrae because some of them fused. In between the ganglia, the part of the trunk in between the ganglia is called interganglionar branches. Yeah, so we have a ganglion, interganglionar branch, ganglion, interganglionar branch. We have the white and gray communicating branch. Yeah, the white ones appears only, or is present only, as I said, at the level of C8 to L3, yeah? But the gray one, of course, goes to every spinal nerve, so it's from C1 to coccygeal, yeah? Where the trunk runs. Can you see it maybe here? Nicely, yeah, you can see it running along the vertebral column. This one is vagus nerve, and you can see as the vagus nerve forms here a plexus, and then it continues down. Yeah, so this is sympathetic trunk. These are then the prevertebral ganglia, abdominal aortic plexus. Yeah, then the sympathetic trunk in detail is also visible here. I will come to this in a minute. Yeah, you see superior, middle, and inferior cervical ganglion and thoracic ganglia. So what is the topography? The topography is on lateral sides of the vertebrae, yeah, within parietal fascia. So which fascia is it in which space? So when we start with the cervical area, we are in parapharyngeal space. Yeah, retrostylate and parapharyngeal space. And the fascia here is which fascia? Prevertebral lamina of cervical fascia. Yeah, you remember cervical fascia has got 3 layers, so this is the deepest one, and it's within the fascia because it's the deepest structure out of all. Then it gets into thoracic cavity, and in thoracic cavity it's located dorsally in superior mediastinum and of course in inferior as well, so in posterior inferior mediastinum. And precisely it's located in front of the head of the rib. Yeah, so we are then oriented, it's in front of the head of the rib. When we get here down, we are in the retroperitoneum, yeah, and it's medial to psoas major and medial to opening of the sacral bone, so opening to anterior sacral foramina. So this is topography, just to understand it. It's also embedded here within the parietal fascia. So this is so-called thoracic parietal fascia or endothoracic, and in abdomen it's endoabdominal or thoracic or parietal abdominal fascia. In pelvis, endopelvic fascia or parietal pelvic fascia. So very easy, not a problem. So we have talked about the sympathetic trunk now, and let's come to the first ganglia. So the most complicated ganglion is the first one. It's a ganglion which fused from 4 smaller ganglia during development, and it's C1 to C4. So that's why we have the gray communicating branch into C1 and C4. Yeah. So as I said, every ganglion has sent gray communicating branch into every spinal nerve. Then we have a small jugular nerve which connects with glossopharyngeal and vagus. Not important for you clinically. But then we have another important one. I come to this last, which supplies heart. Every cervical ganglion supplies the heart. So from every cervical ganglion, we will have an air into the heart. Yeah. So when it's called superior ganglion, we have superior cervical cardiac nerve. Then we have laryngopharyngeal branches. Laryngopharyngeal branches, as the name says, innervates larynx and pharynx. What does it innervate there? Mainly glands and vessels, yeah? So this is sympathetic visceromotor innervation. The parasympathetic, of course, come from vagus, and somatosensory comes from glossopharyngeal and vagus. So pharyngeal plexus is then formed by vagus and glossopharyngeal and sympathetic trunk. Yeah? So we have three nerves which forms the pharyngeal plexus. And now these two nerves which form plexuses around vessels. Another important information for sympathetic system is it forms plexuses around vessels. You already know some of the names. You already know the name external and mainly internal carotid plexus, because internal carotid plexus is a content of carotid canal. Yeah, we have learned this. So please remember, sympathetic system forms plexuses around every artery. Yeah. And this is just a short nerve coming from the ganglion to the vessel to form the plexus. And you can see that they innervate ganglia. Yeah? But this ganglion serves for synapsing of sympathetic system. These ganglia are parasympathetic. So what happens when the sympathetic system comes to the ganglion? Yeah? Parasympathetic system is in this ganglion synapsed. And parasympathetic system, which has been synapsed here, just passes through. Yeah, as this is centrally located, sympathetic, this is peripherally located, parasympathetic. Well, these two ganglia are inside the skull. Yeah, pterygopalatine inside pterygopalatine fossa, ciliary within orbit. So it is supplied by internal carotid plexus. It's inside. These ganglia are below the skull. Yeah, otiganglion in infratemporal fossa and submandibular ganglion in submandibular triangle. So it's outside the skull, so it's innervated by external carotid plexus. Yeah. How it gets into the ganglia? Using the closest vessel. So submandibular triangle is pierced by facial artery. You know it. Otiganglion, another nerve within this area is the auriculotemporal nerve, and the auriculotemporal nerve makes a loop around meningeal artery. So this is auriculotemporal nerve, yeah, branch from mandibular, auriculotemporal nerve, sorry for that. And the vessel here is middle meningeal artery. So you can see it forms here close a loop around, yeah. During the development, it just, the artery grows through the fibers of the nerve. And that's why this artery supplies this ganglion, which is just close to it. As for the internal carotid plexus, it is again something which is close. Ophthalmic artery supplies the orbit, that's why ophthalmic plexus. And the deep petrosal nerve, together with the great petrosal nerve, goes through pterygoid canal to supply pterygopalatine ganglion. We will talk about this again in detail, yeah? But now just to understand why these vessels. And then we have some smaller ones, caroticotympanic, which comes into tympanic cavity, yeah, and you know them, passing through the homonymous canals. And then we have these smooth muscles in the orbit. I will talk about their function in several minutes. So this is really complicated, the superior cervical ganglion, as it supplies. What is inside the skull? What is outside the skull? It supplies larynx and pharynx, and it supplies heart as well. Question, is there any? Okay, then then I'm going to show you the ganglion is here. Yeah, and you can see some fibers. The great communicating branches are these ones. Yeah, and you can see how they go into spinal nerves of the forming cervical plexus. Then there's a communication here between the glossopharyngeal and vagus. Between vagus and this. It used to be called. I just go back to show you. It used to be called the jugular nerve. Yeah, and I said it is not important, but you can see it's here. And then, as you can see, this it comes to internal carotid artery forming the plexus. So this is internal carotid nerve. And here you have the external carotid nerve for the plexus of the external carotid artery. Yeah. These fibers goes to larynx or pharynx, so they are the laryngopharyngeal nerves. Well, and as this is the deepest structure, it is not so easily accessible during operations and even dissections. So we have talked about the superior. Now we will talk about the inferior, the middle, and then the inferior. And you can see that the inferior is fused with the first thoracic. Yeah. So this is what we are going to talk about now. Again, 3 ganglia. Yeah, the superior, middle, and the inferior here. I will come to that in a minute. So what about the middle one? The middle one is visible here. It's close to thyroid gland, so it gives branches to vessels going to the thyroid gland, so branches to the inferior thyroid plexus. As every ganglion in the neck, it supplies heart, yeah, so middle cervical cardiac nerve. And as every ganglion, it gives a gray communicating branch, in this time C5, C6. So it's a small one. And this is the inferior one. Sympathetic trunks here. But in here, in front of the artery, you can see that there's also a fiber. This fiber forms the same as I showed you in middle meningeal artery and auriculotemporal nerve. Yeah, so here we have the middle ganglion, and here we have the inferior ganglion. Sympathetic trunk, yeah, truncus sympathicus, and the fibers which run ventrally are called ansa subclavia. Ansa means a loop, a subclavian loop, but it's in English it's also called ansa subclavia. And the content here is subclavian artery. Yeah. And we nicely see it during dissections. Yeah, this one. And it is here again due to the fact that the artery during the development grew through the nerve fibers and divided it. So that's the middle ganglion, and now the inferior ganglion. And the inferior ganglion usually fuses with the first thoracic. And when it fuses, it is called cervicothoracic, or as it has got many branches, and it is quite round or oval, it is called a star-shaped stellate. Yeah, maybe it looks as a spider more than a star, but it is another term which is used. Cervicothoracic or stellate. What are the branches? Again, some gray communicating branches, C7 to T3, something for the heart, inferior cardiac cervical nerve. Yeah. Then we supply the vessels, which are the closest vessels. That means subclavian artery and the whole upper limb. Yeah, so the whole upper limb. And the subclavian artery gives the vertebral artery. So we have also the vertebral plexus with via very small, via very short nerve, vertebral nerve. Yeah. Why it's important to know about the upper limb? So imagine a patient with sweating of the palms, yeah, sweating of the hands, mainly the palms. You try to cure it somehow. You try to block the sympathetic system. If it doesn't work, what you can do, you can destroy this ganglion. If you destroy the ganglion, there is no sympathetic innervation coming here, and the terrible sweating can stop. Yeah. So that's why you should know that it also gives the subclavian plexus. And I have to stress that we are already at the level of C8. So the sympathetic fibers finally come from spinal cord to sympathetic trunk. So we have here finally present the wide communicating branches. And if you come to a figure, here is the fused inferior cervical and first thoracic ganglion into so-called cervical thoracic or stellate ganglion. Yeah, this is the ansa subclavia. So here you can imagine the subclavian artery, yeah, in between passing. So that's the location of these ganglia. So now let's talk about a very specific syndrome. It's called a syndrome of two physiologists who first describe it, one in French language, one in German language. So it's called Claude Bernard Horner's syndrome. Yeah, syndrome of Claude Bernard and Johann Friedrich Horner. How their syndrome looks like. Here are some symptoms, and we have to explain why the symptoms are like that. Yeah, very important. We also examine this. So, okay, I'll go back, and it can happen when we cut this. So when we cut the cervical part of the sympathetic system, yeah, the cervical sympathetic fibers. When we cut them, of course, usually during in some diseases, it's not cutting, it's usually compression or destruction by a tumor. So what happens and to which structures? So we have meiosis because we know that sympathetic system innervates the dilator, in English dilator, in Latin dilatator pupillae. So it's a muscle which dilates your pupil. That means if you would like to fight, your pupil is enlarged. If someone is sympathetic and you like him, your pupil is enlarged. Yeah. So please remember that the dilator of pupil is innervated by sympathetic system. So the function is mydriasis. Yeah. If there is no mydriasis, if there is no function of dilator, there is no mydriasis. There is the opposite one, which is called meiosis. Yeah. It's usually on one side, as you can see here. And if it's different in the right and left eye, we call it anisocoria. Yeah, chorea is another term for pupil. Iso, that it's similar, it's identical, and aniso, it is not identical. Yeah, anisocoria means that your pupils are not identical as for their width. Ptosis. We have here a muscle, and this muscle is called musculus tarsalis superior and inferior. Yeah? Again, a smooth muscle, and this muscle is within the eyelid. Yeah. It's within the eyelid. So what is the function of these muscles is it helps to open the eye cleft. Yeah. Of course, the main muscle is the orbicularis oculi, innervated by facial nerve, but this smooth muscle also innervates this area. So, in case there is an interrupted function, then especially the superior one, when it's blocked, you have problems with here. You're gonna see that the eyes drop down, and we call it ptosis. Please, could you write me into the chat another cause of ptosis, of a lowered upper lid? We have talked about this before. Why the color of iris is a bit different in each eye, I will explain you a bit later. Or I can explain it now, as it's an inborn. In this case, it is not an acquired, but it's an inborn problem, yeah? Bell's palsy, no. In Bell's palsy, we have lag of thalamus, yeah? Lag of thalamus, that means the inferior eyelid goes down. I don't know what is CBD. It's nothing in anatomy. And we are talking about unilateral ptosis, yeah? Oculomotor nerve palsy is perfect, Razam, yeah? Oculomotor nerve palsy. So ptosis can be symptom either of the oculomotor nerve palsy or cervical sympathetic palsy, yeah? So why anhidrosis? What does it supply? It supply sweat glands, yeah? Sweat glands. Sympathetic system supplies sweat glands. As we said, it uses acetylcholine muscarine receptor. And what is the function? The function is sweating, yeah? And hydros means sweat, yeah? Do not forget that hydros with Y is water, yeah? So it's just an information, do not mix it. So if there are no sweat glands, so what happens? You have a face, and especially your forehead is without sweat, so it's dry, yeah? And enophthalmos comes from musculus orbitalis problem. Where is located musculus orbitalis? Please write me into the chat. Where is the location of a smooth orbitalis muscle? Where we can find it? Okay. No idea where we can find orbitalis muscle. We find it within inferior orbital fissure. Yeah. So within inferior orbital fissure. Yeah. So the function of the muscle is to keep the eyeball a bit moved forward, just a bit. Yeah. So if it does not work, and you may remember that the inferior orbital fissure is a bit larger than the superior one, so the eye can move several millimeters dorsally. And if this muscle does not work, then really the eye is in like enophthalmos. We can have an opposite exophthalmos in some other diseases, but in this case enophthalmos. So you can see that the eye is a bit in, backwards moved or inside the orbit moved. That's enophthalmos. We do not see that this part of the face is dry, anhidrosis, but we can see the lowered lid. We can see the meiosis, so the anisocoria, different width of the pupil. So please, do you understand the symptoms of this syndrome? No questions? It seems everything is clear. So it can be inborn, yeah. If it's inborn, you can have a difference in the eye color, which is called heterochromia. Yeah, chromos color, heteros different. And there's a special reflex which you can try during the break, which we will have like in some 10 to 15 minutes. And you can try a reflex if you do a pain stimulation of the skin at the neck. Yeah? If you pinch yourself into the neck skin, you can see a dilation of the pupil on the same side, which we call a ciliospinal reflex. Yeah, cilio, because ciliary body within the eyeball is the organ responsible for dilation and of or within the ciliary body we have the muscles which do this. So that's the ciliospinal reflex. And so when you see these symptoms, you should think about where is the problem. So the problem can be where we have talked about that. Yeah, that means here from the spinal cord, I'm sorry, here from the spinal cord into the ganglion cervicothoracicum, yeah, and up to superior cervical ganglion where it's synapsed, and then up here to the eye, yeah, and to the other structures, like here the superior tarsal muscle for the ptosis, here the dilator for meiosis, and then of course to the skin and to the orbitalis muscle for enophthalmos and anhidrosis. So when is the problem here? In the internal carotid plexus, it can be caused, for example, by a tumor in the cavernous sinus. And we know that internal carotid artery runs through the cavernous sinus. The problem can be also here in the cervical sympathetic system. For example, it can be a compression by a lung tumor, which will be in the top of the lung. Yeah? The apex of the lung is covered by cupula of pleura, and you can palpate this above your clavicle in supraclavicular fossa. And if you have a tumor here, it can affect any structure running above, which is, do you have any idea which structure can be affected by a tumor growing from the apex of the lung up through the cupula of pleura, yeah, through the vault of the pleura up? Which structure we can find in the supraclavicular region? A big structure. Give me some idea. Of course, one of them is the sympathetic trunk. Yes, one of them is sympathetic trunk, and I would like to hear another 3 big structures. Brachial plexus, perfect. Ferrand, perfect. Subclavian artery, perfect. Moses, Corbinian, perfect. And of course, subclavian vein. Yeah. And now you know another structure, sympathetic trunk. And of course, the problem can be within CNS. Yeah. So it can be within CNS as it goes from hypothalamus all the way through brain stem. So we have 3 neurons. It's 3 neuronal tract, and anywhere if there's a problem, you can see these symptoms. But of course, if the symptoms will be, for example, I change the color and show you here, then there will be some more symptoms for the upper limb. Yeah, so you will have also a dry upper limb. If it will be here, the symptoms will affect another tracts which run within the brainstem and spinal cord, so you will have another symptoms here. Yeah, so then it's important to understand these symptoms separate, and then you look for other symptoms and you are able to find the level of problems. So this is a nice example of clinical anatomy. Question. If not, then we go to thoracic ganglia. Thoracic ganglia are in number a bit less than a number of vertebrae. And what they have, as for the branches, it's very, very easy. All has to have great communicating branches. We are between C8 and L3, so all have wide communicating branches. Yeah? Of course, they supply vessels. So there are some vascular branches. Yeah? So here is missing S, vascular branches. And they form a plexus around thoracic aorta, which is very thin. Why? This plexus is quite delicate, quite fine, as the branches from a thoracic aorta are quite few and they are thin. Posterior intercostal arteries, some small bronchial arteries, yeah, nutritive circulation for lungs, esophageal, mediastinal, so there are few of them. But there are branches from the heart. We said that the heart is innervated by more of them. So you have superior cervical, middle cervical, inferior cervical, and then you have usually 3 thoracic, yeah? T2, T3, T4. T1 is part of the inferior cervical. Yeah, so this is for the heart, as you can see. We call them thoracic cardiac, and these were cervical cardiac. Then we have some for the heart, of course, for the heart, for the lungs. We call them thoracic pulmonary branches. And parasympathetic comes from vagus, which we call bronchial. Yeah? Bronchial branches are parasympathetic. For lungs, thoracic pulmonary are sympathetic for lungs. Of course, esophagus, yes, as we are located, as the esophagus is close to it. And these are in the upper half. Yeah, so this is upper half. In lower half, all the branches are destined to mainly for the abdominal cavity already. Why? As we know, that the diaphragm forms a vault, and the vault is at the most cranial part, it's within the 4th to 5th intercostal space. So from the level of the 5th one, we already supply the abdominal organs via 3 big nerves: major, minor, and immus thoracic splanchnic nerves. And you know these names as they pass through the diaphragm. Yeah? Okay. Now we move further on. Here we can see how it looks like. So these are the ganglia, yeah, thoracic ganglia, and you can see from the lower ones that there already emerges this, which is the major thoracic splanchnic nerve, and you can see it here as well. Yeah, from the level T5 to T9, from level to T9, from level T9 to T11, we have another nerve, lesser thoracic, and they have very small one, immus. Immus means the lowest, yeah, and it's only from T12. And they all 3 enter the ganglia which are here, and these ganglia we call pre-vertebral ganglia. So they are the ganglia of abdominal aortic plexus. So we have 3 splanchnic nerves passing through the diaphragm, through the lumbar part of diaphragm, as we can see here, yeah, through the lumbar part of diaphragm. This one is phrenic, yeah, this is a phrenic nerve, and these are 3 splanchnic nerves, and this is already sympathetic trunk with the lumbar ganglia, azygos and hemiazygos vein, and aorta. Lumbar level. So at lumbar level, similar information again. At every level, Gray communicating branch. White communicating branch only until L3, as I said, C8 to L3. Yeah. Vascular branches to smaller vessels, lumbar arteries. And again, we have some splanchnic nerves. Yeah. In this case, we call them lumbar. We have 1 to 5. Yeah. But the first 3, which contains also the white communicating branches, as the thoracic splanchnic nerve supplies the prevertebral ganglia, so the abdominal aortic plexus. I will talk about in a minute. But the lower ones, they come to another plexus which is a bit lower, and it's called superior hypogastric plexus. And the level of its location is promontory, promontory of the sacral bone. So when we look here, you can see nicely sympathetic trunk with the lumbar ganglia. Here you can see 2 branches at the first 3 levels. So we can see gray and white communicating branch, and L4, L5, only 1, only gray communicating branch. Yes. Then we can continue down the sacral ganglia. Yeah. There are 4 of them, and at the end there's another ganglion. So when we have the sympathetic trunk of the right and of the left side, it's like this. And then this is S4, yeah, S4. And then the last ganglion is here, the coccygeal ganglion, but it's called impar. Yeah, so it's ganglion impar, this one. Impar unpaired. And the fibers here are called ansa subclavia. I'm sorry, ansa sacralis. Sacral ansa. Yeah, sacral loop. These are these fibers. I can maybe draw them by a different color. This and this, yeah? So a loop which connects both sympathetic trunks here. So the sacral ganglia we have talked about now. So we have gray communicating branches, no white ones. We have vascular branches to parietal branches from internal iliac artery, mainly lateral, sacral, inferior, superior gluteal. And then we have, of course, the splanchnic nerves from each level, and they go to the superior and inferior hypogastric plexus as well. Yeah, here should be also the name inferior. We will talk about these in detail so we will understand them. And we have talked about the sacral ansa, sacral loop, which is the loop between the last sacral ganglia, the 4th one, and the impaired ganglion at the end. So this is just to summarize. And now, last important informations are about the plexuses. Yeah, the abdominal aortic plexus and then the superior hypogastric plexus. So to show you where is the plexus, you can see the abdominal aorta, and there are many autonomic fibers which you can find in front of the aorta. Yeah? And the level is approximately here. What is above is called abdominal aortic plexus. What is below is called superior hypogastric plexus. Yeah. So let's talk about the abdominal aortic plexus. It receives sympathetic fibers from the nerves we have talked about now. So greater, lesser, and the least thoracic splanchnic nerves. Yeah? And fourthly, lumbar. The 4th and 5th goes already down to the superior hypogastric plexus. But this plexus also receives parasympathetic fibers, yeah, via vagus nerve. So the vagus nerve brings the parasympathetic fibers into this plexus. The question is why? The answer is easy, because this plexus is around abdominal aorta, and its branches, unpaired and paired branches like celiac trunk, mesenteric arteries, renal arteries can now supply all the organs with both sympathetic and parasympathetic fibers. Yes. So this plexus is a mixed plexus around abdominal aorta, and it contains the ganglia. And these ganglia are the prevertebral ganglia. How many of the ganglia we have? So the smallest ganglion is aorticorenal, next to a renal artery. Yeah, it's a very small one, and it's paired because renal artery is paired. Then we have superior and inferior mesenteric next to the unpaired superior mesenteric arteries. And then we have celiac ganglion. But celiac trunk is very big, so the ganglia is paired. Even celiac trunk is unpaired. But it ramifies very soon into common hepatic to the right and splenic to the left, and then the small left gastric. So that's why we have paired celiac ganglion. Yeah, so we have 6 ganglia, 6 prevertebral ganglia, which we can see here. Yeah, inferior mesenteric ganglion here, superior mesenteric ganglion here, aorticorenal, small one paired, and big one paired celiac ganglion above the celiac trunk. So 6 ganglia within this plexus. What does the plexus innervates? It innervates all the organs which are supplied by these vessels. That means foregut, midgut, yeah, and it innervates other organs which are supplied. Splenic artery, spleen, renal artery, kidneys, and part of ureters, yeah, suprarenal, middle suprarenal glands, testicular, ovarian, testes and ovaries, and the ovarian artery also supplies part of the uterine tube. Yeah. So if you know vessels, not a problem in innervation. Yeah. Of course, it supplies pancreas and liver, which are pouches of foregut. So I think no question to that. Another figure showing you the richness of the autonomic nerve fibers and the plexuses around individual vessels. And it continues under the level of L3 as a superior hypogastric plexus. Why do we distinguish the abdominal aortic and the superior hypogastric? If you look here, there is no need to distinguish because it's a still one plexus morphologically. But the superior hypogastric plexus is pure sympathetic, yeah, as it already innervates the part of the hindgut, the descending colon, and the vagus does not come to this system anymore. Yeah, so superior hypogastric plexus is pure sympathetic plexus lying on promontory. As it descends from promontory, we can see here it's lying on promontory, and as it descends, it forms here and here such 2 chains. Yeah, it's located here, and when it descends, it forms a chain, and then again there's another plexus. This plexus is in pelvis, so it's sometimes called pelvic plexus. Yeah? And to distinguish it from this, which is superior hypogastric, we call it inferior hypogastric. And this chain which is in between is just called hypogastric nerve. And what was here above was the aortic abdominal aortic plexus. Yeah, and the level is L3. So the abdominal aortic plexus is mixed. It continues as a pure sympathetic superior hypogastric on promontory. Then it constitutes a paired hypogastric nerve, which then again fuses to form this inferior hypogastric plexus. This and this are mixed. These two are pure sympathetic. Yeah. Here comes parasympathetic by vagus. Here comes directly from S2, S4. We will talk about this after the break. Yes. So, superior hypogastric plexus on promontory forms the right and left hypogastric nerve, and they again fuse into inferior hypogastric plexus, which is mixed and supplies all the pelvic organs without ovaries, because it descends from above, yeah, and the half of the uterine tubes, and branches from ovaries and uterine tubes, they reach as far as the fundus of uterus and fundus of urinary bladder, yeah. They are quite long, so that's why they reach up to these two organs. But majority of uterus and majority of urinary bladder is innervated by inferior hypogastric plexus. And of course, the superior hypogastric plexus is lying on the promontory, which we can see here. Yeah, but it also gives branches here to the sides. So not only running here into hypogastric nerves and then down, but also here, forming plexuses around the vessels, yeah? As sympathetic system forms plexuses around the vessels. So it also supplies the whole lower limb via common iliac, external iliac, femoral, popliteal, and so on, via these plexuses around the arteries, yeah, homonymous plexuses. The last information before the break is that the limbs receives only sympathetic fibers, yeah? They receive only sympathetic fibers. And they receive the sympathetic fibers via two ways, yeah? And I will show you how. So you can imagine we have a spinal cord, and in the spinal cord, the gray matter, and from the gray matter, we have the visceromotor sympathetic fibers, yeah? They go through the anterior root, then the spinal nerve, and then the white communicating branch. Then it's interpolated, and then it goes into the lower limb. How it can get into the lower limb? So it can get the way we have talked about, yeah? So into the abdominal aortic plexus. So abdominal aortic plexus. Sorry. Then to the plexus which continues, which is superior hypogastric. And then iliac plexus and femoral, and we are in lower limb. Yes, that's one way. And then the other way is back to the spinal nerve. We can draw the spinal nerve here. That's the gray branch. Yeah. So back to the spinal nerve, and via the nerve again to the lymph. Via which nerves? The answer is plexus lumbalis and sacralis. Yeah. So the postganglionic fibers can get into the limb via two ways. One is along the spinal nerves, yeah, because we have here the great communicating branch. Yeah, this is the gray one, and then it goes together with the anterior ramus to lumbar plexus and sacral plexus, or it goes via splanchnic nerves to the abdominal aortic, superior hypogastric, and then common iliac, external iliac femoral, yeah, and then again to the organs. Of course, for upper limb, it goes this way up and then to the upper limb, yeah, via the subclavian plexus. So please remember, limbs has got only sympathetic fibers and via two pathways, yeah, using plexus and using brachial or lumbar plexus or sacral plexus, and via plexuses around the vessels, so perivascular plexuses. Yeah. Questions? If there are no questions, break to 12:40. If another pathways get damaged, would be able to move the limb still. Of course, these are visceromotor fibers, so they are not for movements. They are not for movements. They are for vessels and skin glands. So yeah, when one of them is damaged, the other one can, within several weeks, overtake the function. Yeah, but it's not somatomotor, so it's not a movement. Yeah, it's only for the glands and vessels. It's visceromotor sympathetic innervation. Okay, another question? If there are no questions, then we'll see each other in 8 minutes and we will continue. Parasympathetic system is called also craniosacral system, yeah, as it leaves, and we can see it here with the fibers colored gray as they leave the brainstem in 3 cranial nerves for the area of head, and the 4th one, vagus, for the rest of the body. And then from here, at the level of S2 to S4, to supply the lesser pelvis and the hindgut. So there's the general information. And now, where are located the nuclei? So the nuclei are the nuclei of the cranial nerves we have studied before. So it's oculomotor nerve. The name of the ganglion is quite complicated, preganglionic part of the accessory nucleus, yeah? And that's why in clinics we use the term Edinger-Westphal after 2 Germans, Edinger-Westphal, yeah? Facial nerve, visceromotor nucleus superior salivatory, close to it, inferior salivatory for glossopharyngeal nerve. So these 3 are for the head, and then vagus and its posterior nucleus, which is for the thorax and abdomen, foregut and midgut. S2, S4, it's the same nucleus as for sympathetic system at the level of C8 to L3, intermediolateral nucleus within the lateral horn of spinal cord. Parasympathetic system parasympathetic system does not reach the limbs, and the ganglia are located in periphery. So they are within the skull, ciliary, otic, pterygopalatine, submandibular, or within the organs, so-called intramural ganglia. That's valid mainly for the vagus nerve and the pelvic ones. So this quite complicated scheme shows everything for the head. So now let's go through this in detail. Yeah, I'll try to explain it how you should understand it. So we start with the parasympathetic fibers from oculomotor nerve. So we are in the Edinger-Westphal nucleus, and the parasympathetic visceromotor fibers run through the oculomotor nucleus, and the same topography of the oculomotor nucleus, yeah, cavernous sinus, superior orbital fissure, common tendinous ring. And then the fibers use the inferior branch and then leaves it to enter the ciliary ganglion. And this is the parasympathetic ganglion, so it's synapsed here, and then it innervates the muscles which are responsible for meiosis, sphincter pupillae, and accommodation of the lens, yeah, to be able to focus at near ciliary muscle. So this is what you know from the cranial nerves, and now we just have repeated it. What about sympathetic system to this? We have talked about this before the break. Superior cervical ganglion is the ganglion where is a synapse the sympathetic system. Yeah, so from here it starts from level of C8. And the nucleus is the intermediolateral nucleus. Yeah, just to have it full. And then, as ganglion ciliare, the ciliary ganglion is within the orbit, we use the internal carotid nerve and plexus, and it gets very close into the foramen lacerum. I'm sorry, I was mixed. Internal carotid plexus gets very close to, yes, foramen lacerum, that's true, but gets up to Turkey saddle, to sella turcica, and gives ophthalmic plexus with ophthalmic artery through the optic canal, and then enters the ciliary ganglion. It is not synapsed, it just bypasses, as it was synapsed here in superior cervical ganglion, yeah, and innervates later. So it's responsible for mydriasis. It innervates the tarsal muscles, and that's it, yeah. And we have talked about the Claude-Bernard-Horner syndrome, and these two, so affection of the superior tarsal muscle and the later can cause, are symptoms of the Claude-Bernard-Horner syndrome. Do you have any question about ciliary ganglion? Okay, we can look at the ciliary ganglion also like this. Every ganglion, yeah, has got a, and for example, now we talk about the parasympathetic ganglion. So the parasympathetic ganglion has a parasympathetic root. The parasympathetic root is synapsed in the ganglion. Then it has a sympathetic root. The sympathetic root is not synapsed in ganglion, yeah? So it just passes through. And then the ganglion is close to a trigeminal nerve branch. And the trigeminal nerve branch, which is somatosensory, so it's the opposite direction. Yeah, this is visceromotor, so it's efferent. This is somatosensory, so it's efferent. So it also passes through, and it's not here synapsed, as it's synapsed in trigeminal ganglion of Gasser, yeah, which we find on the apex of the petrosal part. So this is a general arrangement. So every ganglion, every parasympathetic ganglion has the parasympathetic root, which is synapsed, sympathetic root, which is not synapsed, and from periphery, a sensory root, yeah, sensory root, which is also not synapsed. So for ciliary ganglion, which is in orbit, and it's located dorsally to the eyeball and laterally to optic nerve, we can say 2 centimeters behind the eyeball and 1 centimeter laterally to the optic nerve, approximately. Yeah. It has got these 3 roots. The parasympathetic root is what we have said from Edinger-Westphal and oculomotor nerve. From sympathetic root, yeah, as we have said, superior cervical ganglion, internal carotid plexus, and ophthalmic plexus. Not synapse, just passes through. And then the fibers which leaves are sympathetic and parasympathetic rented together, which are called, in case of ciliary ganglion, short ciliary nerves. and then supply all together the parasympathetic part, which is ciliary muscles and sphincter of pupil, parasympathetic part, which is dilator of pupil, and outside the eye, the tarsal muscles. What is not mentioned here is the somatosensory route, which is passing through, and it's passing into the ophthalmic nerve. When I'll come back, you can see here the parasympathetic route, which is this. Yeah? Passing like this, and then continuing in nasociliary nerve, and nasociliary nerve is branched then of ophthalmic one. So that was for the ciliary ganglion. Now a bit complicated ganglion is the pterygopalatine ganglion. Yeah, pterygopalatine ganglion within pterygopalatine fossa gets parasympathetic from facial nerve, which comes from the superior salivatory nucleus, and the parasympathetic fibers runs through the route which is called intermediate nerve. Yeah, enters the internal acoustic meatus and the facial canal, which is here, and in geniculum takes a detour into greater petrosal nerve canal. So I had the greater petrosal nerve and the nerve of pterygoid canal, which you already know from the skull, into pterygopalatine ganglion. Sympathetic system comes how? Again, C8, superior cervical ganglion and internal carotid plexus. Yeah, we are inside the skull. And then deep petrosal nerve. This is a nerve maybe you have heard before. It's a very short nerve branching from foramen lacerum, yeah, and joining together with the greater petrosal nerve. So greater petrosal, which is parasympathetic, and deep petrosal, which is sympathetic, forms a mixed nerve of pterygoid canal. Of course, sympathetic is not synapsed, and then it goes into palatine glands in oral cavity, nasal glands in nasal cavity, nasopharyngeal glands in nasopharynx, and lacrimal gland in orbit. So the function is production of the fluid in one side of the face: eye, nose, mouth, and nasopharynx. And it also gives branches to the orbitalis muscle. And we may remember the orbitalis muscle is within the inferior orbital fissure. And if its function is impaired, the eye gets a bit backwards and ophthalmos, yeah, part of the Claude-Bernard-Hornes syndrome. Question to this. I think again it's easy. So we can go on. Another ganglion is the optic ganglion. Optic ganglion is inside infratemporal fossa. How we get there? We get there from glossopharyngeal nerve. Yeah, glossopharyngeal nerve runs through jugular foramen, which is here. Yeah, jugular foramen. Then it gives the tympanic nerve. The tympanic nerves run into fossula petrosa and tympanic canaliculus. Now we are in a tympanic cavity. It forms here a plexus on a promontory and goes through the roof, superior wall, as the lesser petrosal nerve. Yeah, here we have the greater, and here we have the lesser. So the nerves now lies next to each other. But then the lesser one goes through the petrous opening or oval opening or foramen lacerum, yeah, one of these, down into infratemporal fossa, joins the mandibular nerve, and is synapsed. Then it takes a course of two branches of the mandibular nerve, buccal or auriculotemporal, into buccal glands or parotid gland. What about sympathetic? Easy. C8, superior cervical ganglion, external plexus because we are outside the skull, middle meningeal artery, as the meningeal artery makes a loop here, or the auriculotemporal nerve makes a loop around the artery. And we are in the ganglion, of course not synapsing and supplying these two glands, parotid gland and the glands which are close to parotid gland on the wall of, lateral wall of oral cavity, the buccal glands. Well, again, I think quite easy. The last ganglion is submandibular ganglion. So for submandibular ganglion, we use again facial nerve. So the facial nerve has got two ganglia from one nucleus. Yeah. So we get again in the facial canal, but down, and then we use a branch from the mastoid part of the facial canal, which is called the canalicus for chorda tympani. So we are again in tympanic cavity, and chorda tympani is passing through and leaving it in a petrotympanic fissure, and coming to a lingual nerve, leaving a lingual nerve and entering the submandibular ganglion. And then coming again into lingual nerve, which takes it to submandibular and sublingual gland, and lingual glands in the anterior 2/3 of the tongue. Yeah. Sympathetic system, C8, superior cervical, it's outside the skull, external carotid, yeah. And facial artery is the artery which is the closest artery to submandibular ganglion. Of course, passing through without synapsing and gets into these glands. Well, questions to this. So the scheme looks complicated and no one wants you to draw the scheme, but the scheme should help you to understand. Question, is the promontory of the tympanic cavity the same as the labyrinthine wall? Yeah, the promontory is the promontory on the labyrinthine wall inside the tympanic cavity. Yes, it is. Well, so I can add another two information, which is taste from anterior 2/3. Yeah, it has nothing common with the system, and here is a taste from palate. Yeah, it has nothing common with the autonomic system, but you can see how it goes. Yeah, nicely. So here again, the tympanic cord takes it back. It's synapsed in ganglion geniculi inside ganglion, and then it goes into gustatory nucleus, which is part of the nuclei of solitary tract. Yeah, gustatory nucleus for taste. And from palate, yeah, it follows the great and lesser palatine nerves, and then passes through the ganglion, but it passes through the ganglion, just passes through, yeah, not synapsed as it is synapsed here. So the ganglion of geniculum is a ganglion for taste. This is just to explain this. And now I will have a question for you. If I will destroy the ciliary ganglion, yeah, by a tumor or by injury, what will be the symptoms? Please write me the symptoms of the ciliary ganglion injury or destruction. Ciliary ganglion destruction. Any idea? If you see the scheme, you may understand it. No constriction of pupil, and there will be, how would you call it? There will be a paralysis of pupil. No movement of the pupil. Why? As you can see, we have here not only dilator, but also sphincter. So, yeah? So you understand this? Of course, there can be a problem with the not closure of the eye, as you can write, but the problem with the tarsalis muscle, so there will be ptosis. Yeah? So not only paralysis, but there will be ptosis, which is not so problematic for the patient. What is the problematic? The patient has a paralysis of the pupil, not able to perform meiosis or mydriasis, and there will be problems with ciliary muscle, so no accommodation, yeah, no accommodation of the lens. So if you destroy the ganglion, even the ganglion is parasympathetic, yeah, so the sympathetic fibers pass through the ganglion. They are not synapsed, but they pass through, yeah, so it's a paralysis of the pupil, no constriction, no dilation. You understand that? Perfect. So the presentation then contains each ganglion, as I have explained in the scheme, with the details, so I can skip this, yeah, it's just for you to have all the information written. And now the last information about parasympathetic system is the inferior hypogastric plexus, yeah, the plexus which is inside the pelvis. So you can see it here, there's the plexus which is here in the pelvis. It gets fibers from S2, S3, S4, and we call them pelvic splanchnic nerves. Yeah? So it's parasympathetic one. But as you can see, it gets fibers here. These fibers are sacral sympathetic fibers, yes, sacral splanchnic ones, as they come from sympathetic trunk. And they also get fibers from here, from hypogastric nerve. Yeah? So you have both parasympathetic coming from S2 to S4 and sympathetic coming from S1 and coming from hypogastric plexus. So it's a mixed plexus, and you can see what it supplies. It supplies the organs in lesser pelvis. It supplies the hindgut. Yeah. So the hindgut, it supplies urinary bladder and prostate. Of course, in female, it supplies uterus and vagina. And it also supplies cavernous bodies. So we have some branches which are called cavernous nerves. So, just to repeat it here, splanchnic pelvic nerves S2 to S4, yeah. Old name erigent nerves for erection. Sympathetic coming from hypogastric nerves, yeah, and from sacral ganglia via sacral splanchnic nerves. It supplies all the pelvic organs except ovaries, which descended, uterine tubes, which part of the uterine tubes which are supplied from ovary, yeah, and then a fundus of uterus and fundus of urinary bladder, which are also supplied from here. And what it supplied, the plexus itself, as I said, it's hindgut, urinary bladder together with the prostate, and deferent duct in female, uterus and vagina, and in both cavernous nerves to cavernous erectile bodies. Yeah. If the scheme is not there, I can add the scheme. I can add the scheme or send you the scheme then. Yeah. It's available at the website of the third faculty where are all the materials. Well, so last two information are about paraganglia and enteric system if you have no question about the parasympathetic system. What are paraganglia? Paraganglia are structures which are also derived from neural crest cells. So they look similar as ganglia, but they have different function. We have histologically two kinds of them. One, if you stain them, they get the stain, so they are called chromafine. They used to be called sympathetic paraganglia, as their function is to produce noradrenaline and adrenaline, as well as the medulla of suprarenal gland. And they are transient structures which are present in fetal period and in early childhood. Yeah. Then we have only the medulla of suprarenal gland producing adrenaline and noradrenaline as hormones. But during fetal period and early childhood, we have another 4 of them, at least big 4 of them. One is called Abdominal aortic paraganglion or Zuckerkandel's paraganglion as the biggest one. It's close to inferior mesenteric artery. Then we have something which is close to the coccygeal bone, in front of the coccygeal bone, yeah? Coccygeal glomus. And we have also jugular glomus in jugular foramen and tympanic glomus within tympanic cavity. These structures, as I said, are important in fetal period and early childhood, but they can change into a tumors. Yeah? So their tissue can be metaplastic and a tumor can develop here, and the tumor is then hormone active, producing noradrenaline and adrenaline, and it's quite a malign tumor. So paraganglioma exists, and you should know where are located the paraganglia. Yeah, and as I said, Zuckerkandel aortic abdominal ganglion close to inferior mesenteric artery, coccygeal in front of coccyx, and jugular and tympanic in jugular foramen tympanic cavity, very small structures. And then the other group, they do not stain well, so they are called without chromafine reaction, and they used to be called parasympathetic, and their function is to perceive the blood pressure and to perceive the partial pressure of the oxygen, that means the level of the oxygen in blood. And we have two big, one is called carotid glomus, and it's within the bifurcation of carotid artery, and the other is called supracardiac or aortic, and is inside the aortic arch. Yeah? So these are chemo and baroreceptors. Again, they can change into a tumors. Rarely, but they can. And the last information is about the entering system. What is entering system? You already know this. These are all the neurons we find in the gut. The number of the neurons is similar to number of the neurons in the brain, so it's a really big brain, and it is concentrated into two big plexuses. Submucous plexus of Meissner, my enteric plexus of Auerbach. Yeah, the function of these plexuses is to govern the glands of intestinal tract and to govern the peristaltics, so the smooth muscles. Yeah, and they are in the extent of the whole foregut, midgut, and hindgut, plus the glands which are developed from that. Yeah, pancreas, gallbladder, liver, and in liver the biliary ducts. The enteric system receives the visceromotor sympathetic and parasympathetic fibers and sends back the viscerosensory fibers, yeah? And the prevertebral and paravertebral ganglia are the ganglia where these fibers meet, and they mediate reflexes, local reflexes which we do not feel, but they are part of our peristaltics. The peristaltics is then managed by Kachlík interstitial cells, which are the pacemaker cells of this muscle layer. Yeah, like sinoatrial node is the pacemaker of the heart. Here we have the Kachlík interstitial cells. So this information we've already got during GIT. Do not forget it. And how is the autonomic system controlled by CNS? It is controlled by three structures. One is called reticular formation, and we know that it's a system of nuclei and nerves in the brainstem, and it's responsible for our basic living functions. So heartbeat, heart rate, breathing, mixtion, sexual functions, reflexes like coughing, salivary reflex, blinking, and so on. Yeah. So reticular formation, brainstem. Then the highest center is hypothalamus. The hypothalamus can control the body via autonomic nervous system, so using sympathetic and parasympathetic, and via endocrine system, yeah, endocrine, using the hypothalamo-hypophyseal axis. And then hormones and autonomic information comes to the effectors. So these are the ways how the body can control its function, yeah? And the controlling center is the hypothalamus. And the controlling center is a bit modulated by so-called limbic system. Limbic system are special structures in cortex and subcortical ones, and the most important for the function of the organs is insular lobe or insula. Yeah. So these three structures, which we are going to talk about in detail in central nervous system, are the structures controlling autonomic nervous system. So questions, because the topic is over. If you have some questions, the test will be next Friday. I assume at 10 in a written form. Okay, if there are no questions, I will stop recording and thank you for attention.